for asking me to speak to you about this perhaps not excessively joyful topic of sudden cardiac death. But what I want to do is just sort of set the scene, so I'm going to really give you a sort of introduction to the topic. So, first of all, I need to discuss with you what we're not going to talk about. So, this is the type of heart disease which everybody is very familiar with, where you've got damage to the heart muscle due to obstruction to blood flow in the coronary artery, resulting in damage to part of the heart muscle. And this is what we commonly call a heart attack. And as I'm sure you all know, it's usually due to lifestyle factors such as smoking or dietary indiscretions, such as here, and perhaps also lack of exercise. But there's a group of people who would seem to do all the right things: don't smoke, don't drink the quadruple bypass burgers, do plenty of exercise, and yet they are still at risk of sudden cardiac death. And it's these people who may have conditions which we call the familial arrhythmias. So one of the sort of best known of those is long QT syndrome, which I'm just mentioning on the slide here, so called because the distance between the Q and the T wave on the ECG is excessively prolonged. I'll get the average here, there it is. And down at the bottom, underneath Kaspersky antivirus, is the ECG. So at the beginning, the heart rhythm is nice and regular, and then what happens sometimes in long QT is you suddenly get a burst of irregular, fast heart rhythm, as shown on that little ECG. And as you can see in this case, it terminates all by itself. So this, if you like, was a non-fatal sudden cardiac death in which the patient recovered. But of course, if that arrhythmia went on for any length of time, then that would not be a survivable event. So that's the sort of thing we're talking about. So if we're looking at the causes of sudden cardiac death, they are things like ischemic heart disease, the coronary artery problem that we've already spoken about, familial arrhythmias, which are often electrical disorders like long QT, but also the inherited cardiomyopathy. So these are disorders of heart muscle, and there is hypertrophic cardiomyopathy where the heart muscle is thickened, dilated cardiomyopathy where it's thinned, if you like, and arrhythmogenic right ventricular cardiomyopathy, which I'll probably call ARVC after this, which is a disorder where the heart cells tend to come apart a little bit and cause arrhythmia. So these are, if you like, the different groupings of causes of sudden cardiac death. So we need a definition of sudden cardiac death. And there are a number of definitions around. This is based on the WHO definition of sudden cardiac death. So we can talk about sudden unexpected cardiac death, to be more precise, which is death arising from presumably cardiac causes within 1 hour of the onset of symptoms. And in addition, a person has to be between the age of 1 and 40 years. If you are less than 1, then you are having a sudden infant death, not a sudden unexpected cardiac death. And if you're over 40, like me, it seems that your death is expected. So therefore, actually, of course, the reason is that below the age of 1, the causes are different. And over the age of 40, the causes tend to be ischemic heart disease, so that the genetic causes become less significant. So looking at this group of younger people, children, young people, and younger adults, we're looking at a rate of between 1 and 5 per 100,000 patient years. So 100,000 patients observed for a year, between 1 and 5 of them would die from one of these conditions. Now, if we look at this pie chart here on the right, this is a series that was done looking at the causes at autopsy of sudden cardiac death. And we can see that the top right-hand corner here, about a quarter of them are due to ischemic heart disease. There's a little wedge down the bottom in green, which are cardiomyopathy, so that's heart muscle disease, inherited. And then there's about 30% which are due to arrhythmia, presumably familial arrhythmia. So these are people in whom the autopsy actually showed nothing at all. There was nothing apparently wrong. and it is assumed that the death was due to arrhythmia. So if we look at this group here, roughly a third of cases where the sudden death has occurred and there's no obvious cause, how do we find out what the cause might be? Now there have been various research studies looking at what the cause might be, and they basically fall into two groups. There's one group of studies where people have looked at first-degree relatives of patients who have suffered a sudden cardiac death. So that is parents, brothers and sisters and children of an affected individual. And they have been investigated clinically to see whether or not they have an identified disorder. And in about half of cases, you can identify an inherited cardiac disorder by doing that kind of study. The other option is what was sort of initially put forward by the Mayo Clinic in their molecular autopsy series. So this was basically a series of patients with sudden cardiac death, nothing seen at post-mortem, and they did genetic testing on all those people to see if they could find problems in the various hereditary heart genes. And they found that about 35% had a mutation in one of the ion channel genes. So most of these are therefore long QT. So we've done a similar audit in northeast Scotland. So this is not quite as rigorously scientific as the studies I've just shown you, but over the last 10 years or so, there have been 172 cases where we had information about the diagnosis. And for various reasons, which I'll come back to in a minute, only 49 had a molecular post-mortem. And in amongst those, 29% had a genetic diagnosis. So this process does work here, as well as in America and other places. We can find a genetic diagnosis by doing genetic testing at the autopsy. So what are we looking at? We're looking at the ion channel genes, which cause familial arrhythmia. We're looking at the sarcomere genes. These are the genes for the heart muscle, the proteins that make the heart beat, for the cardiomyopathies. And we're looking at cell junction genes for ARVC, or arrhythmogenic right ventricular cardiomyopathy. You could say all these disorders have things that you can detect by standard tests. So why don't we just do the standard tests, ECGs, echocardiograms, etc. And one of the answers to that is that in life, some of these tests are normal, even in people who've got these conditions. So they're not manifesting all the time in everybody. And in particular, of course, that's the case for younger people. The younger you are, the more likely it is that you might be missed by this kind of screening process. And what we want to do is to diagnose people at an early stage so that we can offer them treatment and lifestyle advice to help them avoid sudden cardiac death. So clinical screening on its own isn't going to work, and genetic testing in this context would help. So this might be a process for a molecular autopsy. If the heart looks normal, you test those genes in the blue box in the middle there, long QT, another gene called RYR2 and ARVC perhaps. Cardiomyopathy, so you look at the sarcomere genes. ARVC, you look at the ARVC genes. And if you find something, you'd then be able to cascade that testing into the first-degree relatives of that person. And although we can't prevent the death of the person who's already died, we will hopefully prevent the deaths of their relatives who are at risk. If you can't do a molecular autopsy, we have a problem. Because as I've said, the clinical tests don't rule out the diagnosis, particularly in young people. So then you're committing yourself potentially to doing the clinical test several times. And for how long should you carry on doing it? Should you do it just once? Should you do it twice? Should you do it until someone's 30? Should you do it until they're 40? I mean, that could be a major commitment for a lot of people who don't actually have anything wrong with them. So there is a big problem if you can't do the molecular autopsy. So having said all that, what is the reason for doing all this? I just want to go briefly into how we actually could follow through to find members of families who have this kind of problem. This is called cascade screening, and it's something that genetics departments do all the time for many disorders. So here we have an imaginary family where a person aged 35 has a sudden cardiac death, and the pathologist suggests that it may have been cardiomyopathy at the post-mortem. What do we do next? Well, we know that he's got some children, but the next thing we need to do is a 3-generation family history. So we do that, and we find out that his father is said to have had a heart attack, and his brother has an abnormal echocardiogram. Now, that's a little bit suspicious that maybe there's a hereditary cause for the cardiomyopathy in the family, but it's not proof. So what we might then do is arrange investigations for all the first 3 relatives and not just those 2. And when we do that, we find that the other people who said they were normal do appear to be normal on investigation, but the father who had the heart attack actually also has, that's this person up here, also has an abnormal echocardiogram. But of course, abnormal echocardiogram could be due to other causes, like for instance high blood pressure, which this patient has. This imaginary patient. So, if we were able to have done a molecular autopsy, we might have found that the original patient had a mutation in the NYEPC3 gene. And those of you who are molecular geneticists will notice that this sequencing run is not this mutation. I told you it was an imaginary family. Okay, it's not necessarily. It's protected against confidentiality. So there we are. So that's the mutation. So that then enables us to screen all the relatives for that mutation. And when we do that, we find that someone who had normal tests, normal echo ECG, actually has a mutation. So that person also has the condition and is at risk. The next question would be, should we test the children? Just for the sake of argument, we're going to test the children in this imaginary family, because it may be that they want to participate in Olympic sports, and so therefore there might be an issue about warning them what that would imply for their, if they have the gene. So now we've got all that information, and having done that testing, we've generated a new set of first-degree relatives, because when we diagnose these 2 people over here, the sister and the brother, of course, they have first-degree relatives themselves. So we then move out into that part of the family and screen them to see if they've got it. And this is why it's called cascade screening. We can go out through the family, through first-degree relatives, and hopefully identify people at risk and offer them lifestyle advice and medical treatment to prevent sudden cardiac death. So that all sounds very fine. But of course, there is a legal basis behind this, and we have to think about that. Mostly, sudden cardiac deaths will have an autopsy at the request of the Procurator Fiscal, because that's how the system works. The Human Tissue Scotland Act has some provisions for this. For instance, it says that after the Procurator Fiscal is finished with investigating the death, any tissue sample that exists will also be retained as part of the medical record. That's a tissue sample, it's not an organ or a body, it's just a microscope slide or a DNA sample. And that sample may be used for providing information about or confirming the cause of death, or obtaining information which might be relevant to the health of another person, including a future person. That sounds fine, doesn't seem to be any problem there. Unfortunately, there's also another human tissue act which mainly applies to England and Wales, except for the provisions about DNA testing. And the Human Tissue Act 2004, England and Wales, creates a crime, DNA theft, or having bodily material with the intent to analyse its DNA without qualifying consent. Although even that act has the rider saying unless it's for an accepted purpose. And accepted purposes include medical diagnosis and the purposes of the coroner or procurator fiscal. I'm not going to go into that any further because I'm sure someone else will in a minute. So, what is the issue? Well, the issue is that sudden cardiac death is often a procurator fiscal matter. The autopsy is carried out on their behalf initially, so the family is not approached for consent at that point. The wording of the English Act creates a presumption against taking samples because of this threat of a criminal activity, which really puts people off taking samples which might otherwise be used for molecular testing or genetic testing. And once the fiscal is finished, that might be some time later, it may become too late at that point to go back and say to the family, now that we've done all this, can we have a sample for DNA testing? Really, that's not going to work. It's got to be done straight away or not at all, probably. So I'd just like to finish there and leave you with these thoughts, which are very much related to the questions that you're going to be asked to answer later on. Should molecular autopsy be routine? Do we really need this kind of special legal protection for gene testing anymore? How should results be given to relatives? Because you can see that there might be problems with anxiety in relation to these sorts of conditions. But on the other hand, how can we ignore the potential to save lives, which this sort of technology offers?